Emma Price, and I'm here with Dr. Sandor Lavas, a renowned urologist in Hungary. I'm going to let him introduce himself and speak a little bit about his work.
Hi, good evening, everybody. I am Sandor Lavas from Hungary, a urologist, and I am dealing mostly with interstitial cystitis in the last 8 to 10 years. I treat up to 500 patients, and I have quite a nice experience with diagnostics and treatment of interstitial cystitis. I would share some ideas, some experiences with you in the next few couple of minutes.
Yes, so let's get started talking a little bit more about ICP-PS, the symptoms, treatment, diagnosis, and any other tips and tricks that Dr. Lavas might have for us. So first of all, what exactly is IC?
Some disease causing very, very serious pain and bad quality of life to patients. The diagnostics is not too easy, therefore the diagnosis rate is quite low. We have to spread our knowledge on this disease in order to get a better diagnosis rate, because patients who are not diagnosed in time, they get in a very, very poor condition and struggle a lot.
Mm-hmm. Can you tell us a little bit more about the symptoms and the kind of pain and what someone with IC might struggle with?
Well, the pain is really one of the most important symptoms this disease causes. That's why the name recommended to use is the bladder pain syndrome. But the pain can be quite different. It can be either very slight or even very, very strong. Mm-hmm. The pain site can also change or can variable in different cases, either located on the bladder, but not always. In approximately 70% of IC patients, the pain is also present in the urethra, or even in a few percent, just the urethra is painful and the bladder is not aching. But the other symptom is very characteristic, that the patients have to urinate very frequently. You can imagine if a patient must go to urinate 20 times in a night or even more frequently, and also over daytime, they have to go or run to the toilet in every 10 minutes or 15 minutes, how this influences the quality of life. And the symptoms can also added by other sites like painful vagina or this region, the genital region, in male patients, because you have to know that this disease is very frequent in male patients too, or even worse the case is because in males the underdiagnosis rate is even worse than in women. Well, in male patients, the pain can be located in the urethra and in testicles and in the perineal region. And because the symptoms show such a huge variation, the diagnosis is difficult because it cannot be based alone on the symptoms. Also, other diagnostic procedures should be taken into consideration.
Right. So can you talk a little bit more about misdiagnosis and what process you use and why there are so many misdiagnoses?
Well, some additional options are there. There are some characteristic signs or symptoms which already the patients diagnose or remark themselves, and also tell to the doctors. And these are that they observed that by drinking less or the liquid consumption reduces in some cases, and this can cause more expressed pain or symptoms. Or in the opposite way, they also observe if they are linking more and more, then even serious pains can be reduced. Another observation is that some patients remark that by drinking some special drinks, first of all, alcoholics, caffeine, or carbonated liquids, the symptoms can get worse. Or from the side of the diet, if they are having spicy meals or have more fruits or fruit juice or tomato, it worsens their condition a lot. Then we also have to ask other questions, like if they remarked some changes of their symptoms if having sexual intercourse. This is also quite characteristics that during sexual intercourse they can have pain, or after it, next day, the symptoms get worse. There are also some other diagnostic steps which we usually can use. This can be cystoscopy, which some recommend in each case, but I think it's not absolutely necessary in all patients. But if the patient has symptoms or pain, although they are getting treatment, especially for interstitial cystitis, and the condition is not improving, or they observe hematuria, either macroscopic or microscopic hematuria, this could be an indication for performing a cystoscopy. Another option is to perform some urodynamic examinations. Nowadays, we don't recommend it to use, not in each case, but just in selected cases. But in sometimes it can differentiate very clearly if the symptoms are due to interstitial cystitis or maybe for overactive bladder. They also can have similar symptoms. It's also very important to know if the patient has some kind of bacterial infection, I mean bacterial cystitis. Therefore, a urine analysis and the bacteriological culture of the urine is absolutely necessary to perform in each case. I have to add immediately, if we find an acute or chronic cystitis, this does not exclude the possibility of having interstitial cystitis, because a corrupt superficial mucus layer, the gag layer, a corrupt gag layer in the bladder, prone the patients to get bacterial infection more often. So it does not exclude the possibility, but to set the correct direction in these cases, we have to try to get rid of this infection, to cure it first. And when after reaching negative urine, the symptoms remain, that's also a cue for the diagnosis.
Mm-hmm. So what would you say it is often treated as instead when patients are misdiagnosed? Is it chronic UTIs, or what are IC patients usually misinterpreted as?
Well, as I told you, diagnosis is quite a long-lasting procedure, and the patients wait sometimes years till they get the correct diagnosis. Most of the patients turn first to gynecologists. And if the gynecologist does not know the disease of interstitial cystitis or doesn't think on it, he might use different treatments. In most cases, they prescribe antibiotics to the patient because they think, based on the symptoms, that the patients may have some infection. And even sometimes, very sad situation, they don't perform any laboratory examination of the urine, but they immediately prescribe antibiotics, in some cases even many times. And this is the most common problem. Even urologists may have incorrect or false diagnosis, and they treat the patient as an overactive bladder or as a chronic inflammation of the bladder, chronic bacterial inflammation, and they think just it is an accident or accidentally got a negative urine result, but the patient must have an infection. In all these cases, the patients get a series of antibiotic treatment, which is not just unnecessary, but also frightening the health situation of the patient, and may have very serious side effects, and even worsens the symptoms because they cannot work, they cannot be helpful because there are no bacteria. So an antibacterial treatment cannot help, but as an irritative agent inside the urine, the chemical agent inside the urine can irritate the bladder even more than the disease itself.
What can lead to this disease, and what do we know about its etiology?
Well, it's a difficult question. I can answer it very easily. We don't know what is the basics of this disease, what is the real cause. We know that the problem which we can find in the background of these symptoms is that the superficial layer of the bladder mucosa, this is a mucus layer, the so-called GAG layer, the glycosamine glycan layer, this is corrupt. This should be a very, very well-functioning barrier on the surface, preventing the bladder wall from any chemical influence of the urine, any irritative effect of the urine, and it should also prevent bacteria to get on the surface and to be able to infect the bladder. And if this function is corrupt, is insufficient, then the irritative chemical agents inside the urine can reach the bladder wall, can reach the receptors in the bladder wall, and this causes the pain. And the chronic chemical irritation of the bladder wall leads to a non-bacterial or abacterial infection inside the bladder wall. And this inflammation, this inflammation has the same characteristics as any inflammation in other organ or on the other parts of the body. It means it makes the blood circulation gets more expressed and causes pain and starts to produce histamine in the bladder wall, which makes the pain more expressed. And this can cause a vicious circle. I mean, the inflammation inside the bladder wall stops producing this gag layer. Therefore, it will get worse and worse, and the urine can irritate more and more the bladder wall. And this continuous irritation after a longer time leads to some irreversible changes inside the bladder wall, scarification, and if it lasts for years or for decades, it can lead to very small end-stage bladder. So therefore, we cannot use real causal treatment because we don't know the real cause. But if we can repair or try to repair, and in many cases we are also successful to repair the gag layer on the surface of the bladder, then we can call it a so-called causal treatment, although we know that we don't know the original cause.
Makes sense. So is there any correlation with age, an age that IC usually first appears?
Well, I would say no, because interstitial cystitis can occur in all ages, from, I would say, from early teenager age till, I don't know, unlimited. My oldest patient was 92 years old. But I would say most frequently it occurs in women and after menopause. So maybe this can be said on the recurrence of this disease. In male patients, I would say the occurrence of this disease is as frequent as in women, but the diagnostic rate is lower. And also in male patients can this disease come in every possible age. So this is about the occurrence of this disease.
Why do you think the diagnosis for men is so much lower for women?
As far as I observed, all these patients are first thought to have some problem of the prostate. Because if the patient is elder than 40, 45, then they are thought to have some BPH, some benign prostatic enlargement, and treated according to this. In younger patients, it is thought to have some prostatitis. Also, if they have a sterile or negative urine, and they call it an abacterial prostatitis, but in these cases, they get different treatments, most of all antibiotics, again, antiphlogistic treatment or alpha blockers, and all these treatments would be unsuccessful. And in worst cases, as I saw in many patients, they also are diagnosed as BPH patients, and they get prostate transurethral resections, which is a horrible situation. Naturally, they don't improve. Also, after the operation, the symptoms remain till they finally get the correct diagnosis of interstitial cystitis. And even in such cases, the treatment which we use can be useful and can be effective.
Mhm. Can you talk a little bit more about treatment? You talked about repairing the gag layer, but can you talk about how, after you diagnose the patient, what are the first steps to treatment and how does this progress?
Sure. We try to treat patients individually. So not every patient who got the diagnosis of interstitial cystitis get the same treatment, because then some patients would get overtreated and the others undertreated. Therefore, just to prevent this situation, we have to find out that after the diagnosis of interstitial cystitis, what kind of stage the patients have in this disease. Just to be able to make a staging, we have to use some tools. One known tool for this are the questionnaires, quality of life questionnaires, which give 10 points. And according to these points on which the patients get on the given answers, we can quantitatively find out what kind of stage the patients have. In addition, we use a special urinary diary where we are looking how the concentration of the urine influence the capacity of the bladder. It's a special 2 days diary. By performing it, we get to know if the concentrated urine irritates the bladder really, and if it causes then a reduced capacity of the bladder. If yes, if we find out that on the day where the patients produce concentrated urine, they will have a smaller bladder capacity, this proves that the gag layer is corrupt and the concentrated salt solution of the urine can have an irritating effect on the bladder, and therefore the patients go more often urinate or cannot hold so much urine inside the bladder. And this is a very, very useful tool. The patients can make it at home. It's a non-invasive way of diagnosis, can be repeated anytime. So it is also useful for follow-up of the patient and to control the efficacy of the treatment. And if we use these tools, we can find out if the patient has just a slight beginning phase of the disease or already an advanced, progressive and more advanced disease stage. In a starting slight symptoms, we usually just use oral treatment, oral protocol, which means we use different oral agents, some medications, some vitamins or additional, not drugs, devices. So we recommend the patients to drink more and more and have a diluted urine. And we use also alkalizing agents because the acidic urine irritates the bladder much more. So these are a package which we at the beginning in initial phase of this disease use, and we control the patients regularly by filling in the questionnaires and performing this 2 days diary. And then after 3 months approximately, we make a control. The patient repeats these examinations and we compare the results. And if there is an improvement based on the results, then we can say, okay, we don't need to go further. We don't need to use more aggressive treatments, but let's remain on this and wait, because there is an improvement. If this treatment does not seem to be effective enough, then we can go to the next step, and then we also use local intravesical instillation therapy. It sounds a little bit frightening for the patients, but we also immediately have to add to it that in our way, as we use, the treatment is non-invasive. So we don't use catheterization to instill the bladder. We invented an adapter over the syringe by which we can instill the liquid just from the orifice of the urethra through the urethra into the bladder without need of catheterization. So we don't hurt the surface of the urethra, which could cause pain of the patients, and many patients would refuse the local instillation therapy because of the pain of caused by the catheterization. So this treatment by this adapter is absolutely pain-free, and the patients like it, and the patients agree of getting this treatment. We instill a special solution into the bladder. I know also in the US there are used many different cocktails, so-called cocktails, to instill into the bladder. But we in Europe and in other countries also mainly use some compounds of the gag layer, like hyaluronic acid, chondroitin sulfate, heparin, and some anti-inflammatory drugs as well. And these cocktails are then instilled into the bladder. The result and the response rate is very good. The patients like it. And as I told, the problem which we can find in these cases is the corrupt gag layer, that some compounds of the gag layer is missing or not enough present in the gag layer. So if we give these gag layer compounds into the bladder, this could be observed as a causal treatment. So we found that this is the most effective form of the treatment. And if we find an improvement of the patients during the course of the treatment, then we can prolong the treatment intervals. And at the starting the treatment, we give it weekly once for 1 month, then we give it biweekly, and after the 3rd month, we give it just monthly once. And it seems to be enough to reach a good condition, and we reach a stable condition of the disease. It means the patients have just very rarely some flare-up for a few hours or a few days, but basically they are in a good condition. Then we can switch to a maintenance therapy, which means that we give the instillation therapy very rarely, based on the patient's condition individually, either every 3rd month or 4th month. And by using this maintenance therapy, we can reach a very good result. I mean, the patients can stay in this stable condition for many, many years. We have patients who are in this maintenance or on this maintenance therapy in good condition, good stable condition since 8 to 10 years already. So this is an option, and approximately 40 to 50% of the patients treated by this combination therapy, oral plus local therapy, maintenance therapy, we can reach this good result.
Mm-hmm. So you're saying if a patient follows all these recommended treatments, they have the possibility to be symptom-free?
Well, yes, it's an option, but we cannot say it for sure she will. But it's very likely that the condition will improve. The patients will have less pain or less symptoms, and approximately 30% of the patients will get a completely symptom-free situation or condition. This is possible. At the starting of the installation therapy or the therapy at all, we cannot find out which patient would respond so well on the treatment and which patient will respond less well, but the treatment is in most cases brings some improvement.
Mhm. And even with all these treatment options, would you say that diet is still very important to all patients? And how do you help find a correct diet for each patient?
Yes, absolutely. As I told you, in most cases, even those patients who get local installation therapy, we perform as an additional treatment, a combination treatment, also oral treatment. And in this oral treatment, the diet plays a determining role. This is very important that all patients should know which meals and drinks are causing harm to them. And they should, mostly at the beginning of the treatment, till we will reach some good result, they should keep this diet very strictly. The diet, different diet recommendations can be found in the internet, so I would not speak too much on it. I just would like to name the most important points, and these are: alcoholic drinks always trigger the symptoms. Maybe the worst is wine or champagne, and dry wine and dry champagne, or red wine, but any alcoholics. Then fruits, because the fruits consist different acids, fruit acids in them, and it gets then into the urine, and it makes the urine very acidic. So fruits or fruit juice, then carbonated soda and other drinks are all very dangerous. I have to name it different types of cola, which consist caffeine plus carbonated gas. It's very difficult, very bad thing to drink. And also spicy meals or whatever, which have a good smell, like also some plant extracts. They also have some aromatic agents in it, which gets into the urine, and inside the urine, these aromatic agents irritate the bladder very much. So we also recommend the patients not to drink some herbal products, extracts, because they would very likely irritate the bladder, either because they have such aromatic agents in it, or because they can also make the urine more acidic. So these are the diet recommendations which all patients use. And naturally, after a while, when they improve, they can try to relax a little bit, to try to lose a little bit the diet, and we recommend to make some changes, to try some meals, but always just one step and one type of meals. They have it, and if they don't feel a negative result within a few days or a few hours already, then they can have it, and they then try the next one. So one by one, they can find their own diet. But if they find something which really irritates their bladder, they should stop experiencing with it, and they should know their own diet which they should take.
Mhm. So overall, it sounds like your treatment plan is very personalized. Would you say that that is the same in the US?
There are some individual differences in different countries. I cannot tell you that in Europe the treatment would be unified. No, it's not yet. Maybe it's even good. Every country has its right to find their own recommendations for the treatment, because the population is also different in Europe. First of all, in some parts of Europe, the patients prefer some herbal product, which is basically not recommended. But if the patients would like to try it, they can make a trial, and if it find individually effective and good for them, they could use it. So we are in this regard a little bit more liberal as maybe in the US. But there are also very huge differences, and therapists can use, and you also use quite different cocktails, for example. Everybody has his own recommendations. So I think it cannot be told that this or that treatment is characteristic of US or of Europe or Asia or Africa or whatever. But in most countries, they have their own beloved recommendations. But also there are individual differences between therapists.
Yes. I guess my last question for you is, do you have any advice for patients struggling to receive a diagnosis?
Well, sure, yes. They should go to different doctors. If they feel that one doctor does not know really what the problem could be, and just gives different medications just to try this and that, and it can be felt that the doctor is unsure what the patient may have. Go to the next doctor, because even some neurologists really do not know much about this disease. Then go to the next one, or look in the internet and try to find their therapists who have more experience dealing with disease, and then try to go to them or try to contact them over internet. Many doctors give the option not to have personal meetings, but over the internet. Some telemedicine is also available in IC patients. So don't stay at the doctor who do not know what you have, and go to the next one. And don't go to gynecologists. In most cases, this is a urological problem, because the bladder and the urethra belongs to the urological system, and the urologists are the appropriate person who can deal with it. There are some countries where, as an exception, where most gynecologists treat this disease For example, in India, the Indian gynecologists are very professional and they can treat very well the IC patients. But in other countries, all in other countries, urologists are the appropriate doctors for that.
Okay. Well, thank you. That's all I have for you. Do you have any final words you want to leave us with?
Well, absolutely. I would say to all IC patients that this disease cannot be cured completely. This is the bad news. But there's immediately the good news that in most cases of this disease, if a diagnosis is made and they get a combined treatment, oral treatment, as I told, much liquid, alkalizing agents, anti-inflammatory drugs, and diets. And if necessary, they also get local installation therapy, possibly not through a catheter, which causes pain and the superficial lesion of the urethra, but using the catheter-free installation method by using this syringe adapter. They should take these treatment, and they have a very good chance to improve, to get rid of the serious symptoms, to be improved in this situation, or in many cases, the completely symptom-free condition is also necessary to reach. Maybe they would need for that a maintenance therapy, so the treatment should be long-lasting, but they have good chance to get rid of their problem. So don't give it up. Find the right doctor who have experience with it, and then the patient will have very good chance to have a good condition. I wish all of them improvement, and don't give up, and seek for treatment and seek for the appropriate doctor. And if you find them, then your quality of life will be improved a lot.
That's
That
great
was my
advice.
final words.
Great. Well, thank you again, Dr. Labas. It's always a pleasure talking to you.
It was a pleasure for me, and I'm glad always to speak about it. I hope more and more patients will know it, and if the patients will get to know what's possible and what good options they have, then sooner or later, more and more doctors will also deal with this disease. Thank you for your attention.
Thank you. Bye.
Bye.